While I do that, let me introduce you to Senthil Vale. He's our Director of Revenue Cycle. Senthil has over 18 years of revenue cycle experience in the industry, as well as being with Emerald Health for over a decade at this point. And, he's got a vast level of knowledge in terms of the whole RCM industry and specifically in terms of specialty practices. He's helped many of our customers achieve the denial rates that you see here. So with that, I will turn it over to Senthil, and he'll take you through the agenda as well as the presentation. Thank you, Senthil. We can't hear you, Senthil.
I'm sorry, Sanjay.
Okay, that's okay. Thank you.
Thank you, Sanjay. Hi, everyone. Today we are going to see a presentation of a specialty practice, how to achieve a 3% denial rate and get faster. Oh. In this webinar, we are going to discuss about why the specialty practices struggling to get paid and why the specialty claims are getting denied, and 3 pillars of the denial prevention: and prior authorization excellent, and denial analytical, and denial prevention versus management, and getting paid faster. These are the topics we are going to discuss. Let's go through one by one. The first, why the specialty practices struggling to get paid. There are a couple of reasons. Many practices, they don't understand the difference between the PCP offers, primary care offers, and specialty offers. If a one PCP claims get denied, means we are going to lose close to $150 to $300. If a specialty provider claims denied, a procedure code get denied, means minimum there is $1,000 and maximum it's up to the specialty wise. So every denial makes a big difference here. And what are the main reason? The prior authorization, it's a first reason for the specialty practices are getting denied here. And then medical necessity. The medical necessity review is not been done properly. And then the $I value procedures and the payer specific rules. Each payers are unique here. So most of the billing companies and office are not following the specific rules and increasing patient responsibility. After the COVID, many payers increase their responsibility, patient responsibility between 20 to 35% here. So we are missing those part actually. And the next, see, in general, the specialty practices getting denied for 5 reasons. Most of the specialty practice, it's not about the sleep medicine, cardiovascular, ophthalmology, any specialty practices, right? When you categorize the denial, it falls under 5 reasons. You can group them into 5 reasons. The main reason is authorization missing. Who is taking control of authorization? It's a front office control. And the next is medical necessity. And the third is a coding error. And fourth is a eligibility issue. And fifth is a timely filing. We can go through this one by one, but if we have a control over this 5 denials, right, we can avoid maximum denials from the specialty practices here. So that once we have a control over the denials, right, that can increase the revenue and reduce the appeals and other work here. See, any practice, any specialty practices, we need to follow 3 pillars. We need to follow 3 pillars for a denial prevention. That is front office, and then mid-cycle, and then back-end intelligent. See, most of the denials starts at the first. For example, when the appointment get booked, right, we need to identify whether the patient is eligible for the service here. Especially with the specialty practices, Not only checking eligibility, we need to check eligibility plus benefit, whether the patient having a benefit plus prior authorization. Once we check all the tick mark in the front office one means maximum denials we can avoid. Like once we have a proper eligibility in place, also patient having a proper benefit in place, also we identified this kind of procedure, sleep study procedure required an authorization. Once we identified all these criteria, right, our 90% of the problem will get resolved here. Then the next step, the next stage is a mid-cycle accuracy. Once the appointment is confirmed, then goes to the documentation, the clinic documentation and the coding. For example, if we get an authorization for a certain procedures, right, the same thing need to be performed in the mid-cycle year. So the mid-cycle accuracy and prior authorization need to be matched properly. Most of the practices fail because they got an authorization for a different procedure and they perform a different procedure here. See, once we identified those gaps, right, the mid-cycle will work properly. Then the last, it's a back-end intelligent. Once the front office did the part properly and the mid-cycle also did the part properly, means the last, it's a billing team. Billing team can analyze the claim and prevent any kind of a scrubbing need to be done, right? They can scrub the claim in advance and send the clean claims to the payer. How can they do? They can analyze the root cause of the previous denial. For example, each payers have a different criteria, different rules in place. Some payers, some codes will be accepted, and some payers they don't accept these codes here. So payer specific rules we need to design. So once we define that rules in advance, right, we can avoid the denial completely. To avoid any denials, these three teams need to be work together and coordination need to be important here. For example, the first team need to identify the eligibility and benefit need to be verified and the authorization need to be obtained for the proper procedure. And the authorization date, the start date and end date is an important. Once we have a proper rule in place, right, then the mid cycle and back end cycle will work properly here. Thank you. The next. See, as I mentioned, right, most of the specialty practices fail in authorization, but authorization having a high success rate. When you apply for an authorization, 98% of the time payers will approve the authorization. 98% of the time payers will approve the authorization. But how we fail, why we are getting more denial? When the payers are ready to give you an authorization, but claims are keep getting denied for an authorization, that is a complete contrast here. First, we need to understand the payer is ready to give an auth, but why the claims are getting denied? Because the people who are requesting for an authorization, right, they are not having a proper information in place. They are not doing it properly. That's why the practice are struggling here. To make this process excellence, right, there are few things we need to have well advanced. Like what, first I will tell you the reasons here. What are the reasons the authorizations are getting denied? The main thing, incorrect CPT code and the wrong servicing provider and experience dot insufficient visit and so many things. But how we can turn this into a successful authorization? First, we need to have a clarity. What kind of a code, what kind of a procedure I'm going to perform for a patient, whether it's a G code, EPIC code, or a procedure CPT code. Once we clearly define the CPT code, right, then we need to mention the start date and end date and how many visit I'm going to use for the procedure. Once we clearly define all these things, right, authorization can be approved immediately. But most of the practices struggling to do it on a timely manner. They do it after the claim, after the service is rendered, or they do it later. But if we do it before the appointment, right? Before the appointment means we can avoid the authorization denial completely. That's why the eligibility team, it's important actually. Eligibility team is the one they need to identify all these areas. When they're doing the eligibility verification, we don't need to do only the activation date here. We need to check whether what kind of a benefit this patient is holding, whether the patient having a proper benefit to visit the specialty clinic, and whether the code is required authorization. They need to identify all these things in advance. Once they identified all these things in advance, right, most of our authorization errors will get reduced here. So the strong knowledge in the front office makes a big difference here. See, once the auth has been placed, right, once auth has been approved, based on the approved date, then we need to book for an appointment. See, most of the practice fail. What they will do whenever the patient calls for an appointment, immediately they will give an appointment. No, we should not do like that. We should have a proper plan here. First, we need to schedule the patient and verify the insurance information. Once the insurance information is verified, then the benefit need to be verified. Once the benefit is verified, then we need to go for a authorization submission. Once auth is approved, then only we need to confirm the appointment. Without getting a confirmation from the authorization, right, we should not go for a appointment confirmation here. So many practices, what they will do, they will apply for an auth, same time they will confirm the appointment here. That's why they are losing many claims here. We need to define a proper workflow. Thank you. The next, after the authorization, how we can define the denials here. The many practices, they don't know how to break down the denials. First, we can break down the denials into multiple categories. We can break down the denials into multiple categories. For example, by payer, by CPT code, by provider, by location, or by root cause here. Also, we can categorize the denial patient specific here. But we are highlighting the 5 important cases. I can go through one by one. By payer. By payer means certain payers follow certain guidelines. For example, Blue Cross have a different guidelines and Aetna have a different guidelines here. Any practices, they will bill minimum 12 payers or maximum 20 payers here. Once we define the top 5 payers, what is the guidelines, how to bill for the procedure? Once we have a proper guidelines for the top 5 payers, right, we can easily avoid all the denials. But many practices, they don't have a contract in place, they don't have a guidelines in place. That's why they failed. We need to spend more time on gathering that information. How much information you gather in advance, right, that can avoid many denials here. Also, that can set up a proper workflow. So getting a payer guidelines, getting a payer trend, right, it's really important. Once we get the guidelines, then we need to define the risky procedure. What are the procedures can be done without an authorization, and what are the procedures can be performed with authorization? So identify the risk of the procedure. Then we can perform. The next stage would be provider. Some provider have a contracting issue, or some provider have other issues here, or some provider will document in such a way the payers will appreciate, or some providers will do a minimum documentation. If a practice having a more than a one provider, means we need to have a standard documentation process. For example, we need to prepare a documentation for a sleep study, means how the documentation should be. We need to prepare a standard documentation and request the provider to follow the same structure for all the patients. So the uniformity will be maintained. Whenever the payer requesting for a medical records, right, our practice can avoid the error. Recently, what we are observing here, many specialty practices are getting audit frequently. See, if the providers are using AI to draft the notes, means payers also using an AI to audit the notes here. Using an AI, they are identifying many errors in the notes and pushing the claim out, and they're requesting more information. To avoid this documentation errors, we need to have a proper documentation in place for standard notes here. So in the future, if any payer is requesting for a medical notes, means we can send the medical notes and get our claim processed here. One more thing, recently what we are seeing for the specialty practices, many specialty practices are getting down coded. For example, if a specialty provider bills for a 99215 or 99214 means their codes are getting downcoded to a 913, 99213 or 212. Why? Because their documentation and the CPT diagnosis code is not up to the mark here. When the payers are requesting for the medical records is not supporting level 4 or level 5 service here. They spend a lot of time they identifying a new problem, but they are missed to document the information. So missing a documentation, each claim losing almost $100. $100. Just see the difference here. If providers are spending huge time, but due to the documentation error, right, they are missing out a huge money in the table. It's not a denied claim, but the documentation problem here. And the next, it's a location. For example, if a provider is visiting a multiple location or performing a service in the office, also visiting the nursing home or visiting the hospital means we need to identify which claims are getting denied frequently, and we need to have a proper plan in place. How we can do it? By doing the root cause analysis. What procedure is getting denied frequently from what payer, and what are the codes are getting denied here? Once we identified all these things, right, that can help avoid many denials in the future. Thank you. The next, see, main thing, it's a denial prevention. We need to see how we are presenting a denial here. The first, fixing the denial, it's not a big thing. We need to prevent a denial. If we keep fixing the denial means that can happen again and again. It's not a productive work here. We need to identify the root cause of the denial and address it and prevent before it's happening. How we can prevent the denial? See, most of the denials can be categorized into three parts. One is related to patient or related to a specific procedure or a claim or related to a provider. All denials can be categorized into three parts here. It might be related to a patient, it might be a coverage issue, or a patient date of birth issue, or any kind of a denials related to patient. We can easily prevent those denials by having a proper eligibility verification in advance. Once we did a proper eligibility verification, right, any denials related to a patient, right, we can easily prevent. The second part of a denial, it's a claim related denial, like a date of service, place of service, or a type of service, or a diagnosis code or CPT code. Any denials which is related to a claim, right? Billing team or a provider playing an important role. They can identify those denials in advance and placing a correct information. They can completely avoid the claim related denial. The last, it's a provider credential related denials here. The provider credential related denial, we need to have a strong denial credentialing team. Once we have a strong credentialing team, right, they can do the credentialing work and make sure provider and the groups are properly participating. So once we do this kind of a breakdown, once the denial team know how to break down the denial, how to categorize the denials properly, right, they can address it surely. Also, we should see the denials on a weekly basis. The many practices struggle because they will see the denial once in a month or 2 months once. But the specialty practices, every week we need to analyze the denial. What is the new denials comes in? What are the new rejection comes in? Why we need to analyze the denial? Because in a week, right, we might lose a $10,000. For a PCP claims, it's a different story. But in a specialty claims, every week, every claim makes a big value here. So we need to know what are the denials is coming up for this practice, how we can stop on the same week itself. If we give it 2-3 weeks, right, that can add up a more AR here. See, many practices, they will identify this problem only on the monthly deck or a monthly report. But waiting at 30 days to see the denials, right, it's not a productive way. Every week we should have a meeting. In that meeting, we need to discuss a three important part. Number one is what are the rejection is coming on for our practice. What are the rejection? And what is the denial? What are the denials coming up on a weekly basis? And how much is the AR? When we have a track of these three things, right, most of the practice can success. Many practices will see the dashboard or a KPI only on a monthly basis. Monthly basis is not a productive way. Doing a weekly basis and understand the denials on a weekly, right, that makes a big difference between a high performance practice to a low performance practice. They are going to do the same thing. How frequently they are doing, that makes a big difference here. And the next, see, the revenue will not come easily. We need to take a step. First, I'll show you the average. The industry average is between 40 to 60 days. But the high performance practice, right? They stand less than a 25 days. How they achieving these numbers? They're doing a simple exercise. They're identifying the errors in advance and sending a clean claim and getting a few denials, and immediately, for example, weekly they need to follow up with a payer. Once they responded to the denials on a weekly basis, right, that makes a big difference. For example, instead of adding more appointment, right, it's not a productive way. We need to convert all our appointment into a payment. That's a productive way. We should not create more burden for the providers. We should bring more money with the same appointment, that increasing the claim percentage, payment percentage. By doing all the cleanup in advance, instead of working on the denials, right, we need to prepare ourselves and getting a fewer denials and follow up with the payer immediately. Also, one more thing, set up an electronic payment here. For example, many practices, right, uh, now they are going around 80-20 percentage. Some practices are even less. 70% of the payment comes from electronically and 30% of the payment comes in a paper. We need to achieve into a 95 percentage. 95% of a payment should come digital. There should be direct deposit. Only 5 percentage, that's a secondary payment, can be a check payment. But wherever the payers are giving an option to turn into an electronic deposit, right, we need to activate those electronic deposit, and money need to reach the payer, reach the bank immediately. So the faster money will make the practice happy. Thank you.
One question I have, Senthil,
Yes.
is what are the typical times we're seeing? I know Medicare pays really fast and a lot of the commercial payers. Can you just talk about what's the typical we are seeing right now?
Medicare is somewhere between 7 to 15 days, Sanjay. Medicare is paying 7 to 15 days here. Some commercial insurance are paying even 10 days here. Aetna, Cigna. Those are the payers now improve the payment date. They improve the payment date. Now the claims are getting faster. Those days are coming produced every year. Compared to last year, payers are paying the claim faster because they are also started using a lot of AI tools. So the providers need to be aware.
Thank you.
Thanks, Sanjay. And the next, it's a KPI. These are the, see, how I can measure my practice. See, something I need to have to see whether my practice in a good shape or not. We are showing the difference between the average practice and the best practice here. So the average practice denial rate somewhere between 8 to 12 percentage. That's most of the practices falls under 8 to 12. If your practice is more than a 12 percentage, then your practice in a risk. But the best practice is having a denial percentage which is less than a 3. Less than a 3. See, how we can achieve this 3 percentage means doing all these things in advance. For example, sending a clean claim. Clean claim rate is important by putting all the information properly. And the first pass ratio. The first pass ratio should have a 95% above. When the clean claim rate and first pass percentage, when you have 95 above, right, you can avoid many denials here. But many practices not preparing the claim enough. They are not putting a lot of efforts in the preparing the encounter. Most of the efforts has been done after the denial here. We need to turn the table, and most of the effort need to be put before the claim submission. That's the smartest way to work. Once you put a lot of effort to the before submission, right, that can turn the denial from a 12% to a 3% here. And AR days, best average is between 5 to 60, but the best is a 35 days. And collection rate here. See, if I'm sending an 100 claim, means 85% of my payment claims are getting paid. I'm losing 15%, means then it's a loss for a 15%. 15% of my appointment out of 100, 15 appointments are getting denied. That's not a productive way. If I'm seeing an 100 patient, means 98% of the time I need to get a payment here, and 2% of my appointment can go for a denial. That is the best class. How we can achieve that number? See, we are not creating more burden by increasing the appointment here. We are doing best work. We are preparing the work properly and getting money from the denied encounter and turning the money. What are the claims is we're going to generate? We are turning those claims into a payment encounters and bringing additional revenue to the practices by achieving a 98% here. Also, the specialty practices. Most of the specialty practices struggle on authorization approval. As I mentioned before, authorization approval is the easiest thing. 98% of the time, auth will be get approved by the payer. When you place a request for an authorization, right, 98% of the time, auth will get approved here. But the people who work for an authorization, right, they don't put enough information in the paper. That's the main reason auth is getting denied here. So we should have a strong team works on the authorization to get an approval, best approval.
I want to make one more comment, and Senthil, you can add to it further. I think one thing also is understanding, like the staff on the practice side or your billing team has to be very skilled at understanding the root cause of the denials. Because a lot of times we see practices are struggling understanding why a claim is getting denied, and they keep on submitting. We've seen sometimes multiple submissions, and the payers keep on denying the claims because the resource who's doing the denial analysis and resubmitting the claims, they do not know how to resubmit the claim. And Senthil, you can talk to that better than I can.
Yes, I can add a point, Sanjay. We saw a practice, the claim has been rebuilt almost 15, 16 times without any changes, Sanjay. Without any changes.
Mhm.
They are keep
Right.
resending the claim 16 times. Out of all 16 times, payers are denying for the same reason here. The first two times they denied for authorization, and the second, third time they keep denying for a duplicate service. They are keep denying. See, the main reason that understanding the denial makes a big difference. If auth is not there, if you are entering the authorization number, does not mean we are guaranteed for a payment. If its auth number is there, but still the claim is getting denied, means then we need to see the second level of detail, whether the authorization number approved for the same procedure, or whether the authorization number approved for what date it falls, whether it falls under the date of service or falls before or after the date of service, or how many visits has been approved here. So fine, go to the details. That makes a big difference here. So once we go to the details of the denials, right, that makes a big difference on resubmission. So going for a rebill, no use. Also, one more thing I wanted to add, Sanjay, here. Many denials, right, we can do appeal and get a payment. But when it comes to the authorization denial, right, appeal will not make any changes here. Appeal will not bring any changes to the denial. Once the claim denied for an authorization, it's a dead inventory. We cannot turn this to a payment here. So working before the appointment and getting an authorization properly before the appointment, that makes a big difference. Thank you.
Thank you.
The next, see how we can achieve this in the next 30 days. In next 30 days, take any specialty. I'm not going to name a one specialty here, but any specialty, we can turn a practice into a best practice here by doing a proper exercise. What are the things we need to do? Where we can start? We can guide you. For example, first we need to understand what are the denials practices receiving. What are the denials I'm getting here? From if I'm a doctor means what are the denials I'm getting? And from what payer? If BCBS, what are the denials? And US, United Healthcare, what are the denials here? At Aetna, what are the denials? Once I understand the denials, then I need to create a proper solution to each denials here. If I don't know where to start, then I'm not having any goal here. First, we need to read the denials here. What are the denials I'm getting here? And understanding the denials and creating a solution payer wise. For BCBS, sleep study code is getting denied. 99513, something like a code is getting denied means this is the solution. And whenever the new claims comes in means I need to follow this in advance. We need to create a proper standard operating procedure for all the denials here, like a step 1, step 2, step 3. Once we started doing this, right, easily we can reduce the denial in the first 30 days here. Next 30 days, what we can do, we can focus on improving the front end work. Once I identified, okay, I'm having a lot of issues in the authorization, means I need to spend more time. Where is a gap? See, most of the people struggle to get an authorization because they don't know how to work on the authorization. By giving a proper training to the team, or educating the team, or guiding them, or providing enough resource, what are the documents they have to use? Once we provide them a proper documentation, proper education, right, the team will obtain the authorization properly. These are the things we need to do it in the second stage. And then coding analysis. See, many practices, right, they're not using a proper codes for a specialty provider. They are less using it or more using it. We need to identify those codes. What are the codes we can use in additionally? Once we do all these kind of things in the next 30 days, right, definitely the practice can turn into a green. And the last stage, see, by doing these two things, right, how we need to maintain it actually by seeing the denial on a weekly basis, by seeing the rejection on a weekly basis. We need to fix a day, like a Monday or any day, whichever day it's best for the practice, and see what are the denials I'm getting on a weekly basis, what are the denials I'm getting on a rejection, what are the rejection I'm getting here. See, if I'm getting a rejection means I did a solution for the last week. Why it's keep happening here? Is that system is making an issue? So understanding the rejection and giving a solution from a system root, from the root cause, that makes a big difference here. So every week we need to react to the denials and rejection. Once we set up a proper workflow, right, within a 90 days, we started seeing a big difference here. The continuous effort and keep doing the same effort for the first 90 days. That can change the practice from a low performance practice to a high performance practice.
I wanted to add one more thing. So I
Yes.
think this is thank you for presenting the 90-day plan. I think one thing to keep in mind is that it's a continuous process. So this is just the first 90 days. The thing is, you can't stop doing what you do on a daily, weekly basis ever, in a sense, right? Because this issue of denials is a continuous issue, right? You have to stay on top of all of these things that Senthil is talking about on a daily, weekly, monthly basis. Have a strong process in place as well as measurements in place. And one thing we find is that if the practice does not submit appeals to the denials, there's more and more denials. And Senthil, you can talk about that as well, which
Yes.
we didn't really particularly talk about. Please talk about that as well. That's a very important point.
Yes. Thank you, Sanjay. Thank you to bring it to attention, Sanjay. So many practices, Sanjay, many practices, they are not responding to the denials. They are not responding to the payer correspondence here. See what is happening. Many practice will feel, okay, I'm losing only one claim or a two claim. Why I need to rebill it, work for the denial. See how the payers thinks means if when they requested for a medical records means practice should respond to the letter and they need to share the medical records. If you're not sharing the medical records means what will happen, they will increase the percentage of a denial and they will put the practice into a watch list. In the future, you will keep getting more denial and more requests for a medical records here. So working for the denial is important. Also, the same time, we need to respond to the payer correspondence. Whenever payer is requesting for the medical records means we need to keep sending them on a timely manner. Many practices, they miss to send the medical records on a timely manner. Excuse me. That's why it's keep getting more. For example, if you're not responding to the correspondence for the 5 letters, if you're not responding to the 5 denials, means what the practice will say, okay, I'm requesting for a medical notes, but the practice is not responding, increase the percentage from 1% to a 2%, from 2 to a 5%. So working for the denial and the same time responding to the correspondence also makes a big difference here. So our practice tax ID and NPI number will be removed from the watch list, or else they will keep mentioning our NPI number or keep adding our NPI number to the watch list here. Thanks,
I
Sanjay.
think
Thanks
that
for
I
bringing
think
to our attention, sir.
the same thing is happening with downcoding. Like we strongly appeal when we see uptick in downcoding, and if you don't appeal it, the payers will keep on downcoding your encounters. We are seeing that, and when we start appealing and on a continuous basis, those payments are getting made at the higher level.
Yes, Sanjay.
And
Also, what I wanted to add one more thing. Sorry. For example, out of recently we had a practice, they are facing a lot of downcode issue. They came to us and we started sending appeal for all the downcodes. 99% of the time, the downcoded claim converted into a payment here. That means if you do a proper appeal, right, definitely payer will make a payment for the downcode. But many practices, they don't do a appeal for the downcodes. They will simply accept it and they will eat the cost. It's not going to happen for a one encounter. It's going to happen continuously for the entire year. It's going to continue for the following year also. So how soon you're reacting to the downcodes, that makes a big difference. That makes a big difference in the future payment. I'll tell you one average easily for a downcode, right? Easily the practice is losing between $100 to $150 here. If an 100 claims getting downcoded, I mean, just imagine how much money you are leaving in the table. So appeal process, front end process and back end process, both need to be strong. They need to be knowledgeable. They need to know what they are doing, how much revenue they are losing in the table. Once they understand the core part, right, the practice will be happy. See, the key takeaway, most of the denials are preventable by doing a proper front end work for a specialty practices. For a PCP, it's a different story. For a specialty practices, most of the denials are preventable because we are the one setting up the service here. We know what kind of a service is going to perform. Once we set up the appointment properly before, right, 99% of the denials, it's preventable here. And prior authorization and coding accuracy, it's a most of the specialty practices facing an issue here. Once we have a clear structure, clear rules in place for this two process, right, then we can avoid the second thing. The third, denial. That's a key word. If the practice know how to manage the denial, right, then it's a good. Once we did the three things, right, the faster payment and obviously our denial percentage will be less than a 3. Thank you. Any questions from anyone? Please let me know.
thank you, Senthil, for a very informative presentation. If anyone on the call here has any questions, please put them in the chat. There are a few questions that came up. Perhaps you can answer those, Senthil.
Sure, sir.
In terms of what is considered a healthy denial rate for specialty practice, can you help us understand that?
For example, any denial, any specialty, it's a or primary care or a specialty clinic. If a practice is running less than a 3%, 3 or a less than a 3, right? That's the best denial percentage. They should not go more than a 3%. That's a best practice benchmark here.
And related to that is how do we understand what to address first, what denial category?
Yes, they can categorize into two ways here. First, they should go for a high dollar claim. High dollar claim is a first priority, plus the filing limit, which payer have a less turnaround time. For example, Aetna having only 90 days for an appeal, or Aetna is having, or Cigna is having only 60 days for an appeal, means we need to identify those payers first and work around it. It's a combination between a payer and then high financial claims, high dollar claims here.
Okay. How about can a small practice achieve these improvements without investing significant amounts of dollars in technology?
Yes, it's not about the small practice or a big practice. When you have a team, when you have a quality person, when you have a proper rules in place, right? Any size practice can achieve this number. It's a same kind of a work they are going to do. The number of claims will get decrease or increase here. If I have a 10 claim, I'm going to do the same exercise here. If I have 100 claims, I'm going to do the same kind of an exercise. But once we have a proper skeleton in place, right, then the numbers will automatically increase. See, all the big practices, they started small. The day one, they're not a big practice. Once you have a clean practice flow, once you have a clean flow, once the practice is giving a return to the doctors, right? Doctors and front office can keep add more appointment. The smaller practice become a medium-sized practice, and medium-sized practice become a big practice here. Everything starts small here. So how small you are keeping up your practice is making a standard policy, right? That easily you are helping everyone. Everyone, you are converting the small practice into a big practice.
Thank you, Senthil. How about what's the single most important action to reduce denials?
See, I'm keep telling the same thing. The front office works, the front office team, right, play an important role here. The front office, for example, eligibility verification and benefit verification and prior authorization. Once we have a clear understanding of this three part, right, 99% of the denials can be preventable. So the patient also will not get upset here. See, when you give an appointment to the wrong patient, and practice also not get a money, also patient will get a money, everything will become a problem. So
Mhm.
the front office need to give an appointment to the proper patient by doing a proper analysis before the appointment. The exercise we do before appointment, right, that makes a big difference here. Also, I don't want my provider to have a appointment for a wrong patient. If I have a 10 patient, out of 10 patients, 7 patient is a payable and 3 patient is not payable, means just imagine how much money doctor leaving there by seeing a wrong patient.
Mhm.
Everything need to be fine tuned from the front office to back end.
All right. Thank you for that. We have another question here. When someone is new uh, to the appeals process, right? Um, is there, how do we understand how to create a proper appeal letter for the downcoding?
Yes. See, first we need to understand, is it happening across all our claim, all our practice, or it's happening only for a specific claim? If it's happening for a specific claim means, then we need to create a standard letter. There are a lot of letters available on online. They can use any one of the letter, and we need to explain the reason why the doctors spend level 4 procedure, why the doctors spend more time on the level code. What they can do, first they need to write down the reason. The second, they need to use the proper sample. For example, let's take a BCBS. BCBS have their own application. We need to start using that application and followed by a medical necessity letter, and third an EOB. EOB. Once you attach it and send it to the right person, once you do this all things right, down code will get into a payment, Sanjay.
Okay, thank you. I think that question came from Alanda. Alanda, if you do you have any follow-up questions on that? You can feel free to unmute yourself and ask that question.
Hi, y'all. This is such great information. Um, Being new to the field. And I noticed that, the young lady, I work in the ER. So I work in a freestanding ER. So I need rather to know, like, where do I go to kind of look for an appeal letter to put together so we will have one, due to, like I said, I see a lot of the insurance, like Cigna down coding, from a 99284 to a 3 or what have you. So, just trying to put together a letter that we can send, once we know that that is warranted, the 99284 is warranted, to be able to send a letter to the payer.
Thank you.
Thank you.
For example, first we need to check whether do we have Cigna. Let's talk about Cigna here. If Cigna have any appeal for letter, most of the payers have a standard process here, standard appeal response here. First, we need to understand whether Cigna is following any kind of an appeal letters or not. Once we identify that, right, the second we need to create a letter. By how we need to create a letter, the header should have the patient information like a patient name, ID number, date of service, and what kind of a service is performed. What kind of a service, like a CPT code. And then the claim number. Many practices miss to use a claim number. The claim number we need to include here. And then the reason why you're doing an appeal. By giving your own words, I'm requesting an appeal. There are a lot of appeal documents available online. Please use any one of them, or we can also share after the meeting here. The proper wording, these are the reason I'm creating an appeal. Then we need to attach a medical records. That medical records, right, that need to prove the service, the level of service. If you're performing a level 4 or level 5 means there are rules in place. The medical decision maker rules there. The rules need to be satisfied. The medical records need to satisfy that rule here. Once the medical records satisfy that rule, right, you can attach as a package. Also, you need to, there are not only Cigna, there are 3 payers, almost 4 payers downcoding it actually. Cigna, United Healthcare, Humana, and then Blue Cross, Blue Shield Blue Cross. If Cigna is doing for your practice, right, please go for other commercial payers also. Other commercial payers also, they might be doing the same thing. So when you're working for a Cigna, right, don't work only for the Cigna, work for all the 4 payers together. Thank you.
Senthil, can you advance to the last slide because that has your contact information in case
Yes.
Amanda or anyone on this call, please reach out to myself or Senthil. You can see his email address under his name. So if you have any specific questions on anything on this presentation, feel free to reach out to myself or more importantly to Senthil because he's our expert, everything RCM. So appreciate. Does anyone have any other questions? I don't see any other questions in the chat at this point. So we appreciate you joining for today's webinar. This has been very helpful. I would, of course, like to thank all the attendees and feel free to get in touch with us. We will send you the presentation hopefully by Monday, a recording as well as the presentation. And a special thanks to Senthil for conducting such a informative webinar. So thanks
Thank,
everyone for attending. Have a good
thank you,
rest of the day
Sanjay.
and enjoy the weekend as well. Thank you.
Thank you, Sanjay. Thank you, everyone. Bye now.